Thanks, Jonathan, for the introduction and a great opening session by Wes. As you say, Jonathan, I'm here to attempt the impossible, so roll up our sleeves and we'll jump right in. It's a 50-page document, but perhaps up to 300 when you include the appendices and supporting material. So I will do my best to do it justice in the time that we have. In terms of disclosures, Jonathan mentioned I'm a grade guideline consultant. I worked with Society of Critical Care Medicine and European Society as one of the methodologists in support of the PADIS guideline effort. I think these aspects of ICU care are becoming more and more present in the minds of clinicians looking after the critically ill. In the past, ICU was all about surviving the critical illness, and there's been a lot more focus on both the quality of the experience of patients during their ICU care, as well as the impact that this has on post-ICU care. The 2018 PADIS guidelines was actually an update of the most recently done 2013 guideline, which was the PAD guideline. We added 2 new topics in 2018, including immobilization as well as sleep. One of the other big changes since 2013 was integrating patients and family members into the guideline development process. Overall, the document contains 37 recommendations and 2 good practice statements. And I think very telling about the data that supported these recommendations is that only 2 out of 37 of the recommendations were strong recommendations. The rest of them were conditional or weak recommendations. Those are synonymous, so I'll use those interchangeably. We also had 32 non-actionable descriptive questions. If you'll allow me a brief moment to discuss how we make guidelines. And we chose to use, or we did use, the GRADE methodology for this guideline, and one that's used by many international societies around the world. And what GRADE does is it incorporates, we do systematic reviews for each of the questions of interest, so it incorporates the best evidence, but not just the best evidence. We also get an assessment of how certain we are in this evidence, assessing different domains. We include critical issues like patients' values and preferences that help guide recommendations. We consider costs, resources, acceptability, feasibility, and all of these things are factored in through this GRADE guideline machine to come up with either strong or conditional recommendations. Strong recommendations mean just do it. The Nike logo, the majority of patients are going to want this intervention, the majority of clinicians are going to provide this intervention in this setting. These are the things that can be used to guide policy. Conditional recommendations recognize that there might be a large minority of patients that are going to choose an alternate course. And by no means are we dogmatic with conditional recommendations, but rather apply them uniquely to each individual patient setting. So these were the guidelines just published last year, and as I mentioned, there's the 5 different domains, and I will do my best to hit on highlights from each of these 5 domains, starting with pain. Overwhelming guide for the pain section is best encapsulated by this good practice statement. It suggests that the management of pain for adult ICU patients should be guided by routine pain assessments, and pain should be treated before a sedative agent. What this is referring to is an analgesia first or an analgesia-based sedation approach. And the idea is that if you treat pain, quite often you're able to avoid sedative agents. Often we use sedative agents to avoid treating the underlying pain. And the benefit of an approach like this is that it takes advantage of certain opioid properties, reducing the sedative needs. However, there's limitations in terms of accentuating the adverse effects that can be seen with narcotics as well. Things like respiratory depression, hypotension, and can be delirium provoking as well. This approach, this idea of using an analgesia-based sedation protocol might not be appropriate for all, and specifically thinking about those in withdrawal, those on neuromuscular blockade, or neurologic patients, which we may hear about more from Vicky next. The next recommendation we're going to discuss is one that was a conditional recommendation to use an assessment-driven, protocol-based, stepwise approach for pain and sedation management. And the focus is really on multimodal analgesia. And rather than picking a single agent and then exposing yourself to the harms of that agent. Rather, the approach should be to use a multitude of different medications to achieve analgesia. And the idea being is that if you're able to use lower doses of multiple agents, perhaps we're able to avoid the negative sequelae of using too much opioid. And we looked at a number of potential multimodal analgesics as part of this guideline, and we'll hit on some of these most relevant ones now. Probably the one that garners the most attention is acetaminophen, and in my opinion, probably one that's drastically underused in the critical care setting. I told you we did systematic reviews for each one of these questions of interest, and this one was not an exception. And we pooled the outcome data when it looked at adding adjuvant acetaminophen to an opioid regime, seeing the effect that it had on pain as well as opioid consumption. And you can see that the use of adjuvant acetaminophen actually improved pain scores, VAS scores, at 24 hours, as well as it was able to decrease the amount of narcotics or opioids that patients used. Now, I think it's important to keep in mind limitations of the body of evidence, specifically that the majority of these RCTs were single center, mostly done in post-op cardiac or abdominal surgery patients, and certainly the availability and costs, specifically of IV acetaminophen, vary depending on different regions around the world. That being said, given the signal of benefit, we came up with a conditional recommendation for using acetaminophen as an adjunct to decrease pain intensity and opioid consumption in critically ill adults. And I think that this is one that is relatively easy to roll out and an intervention, as I mentioned, that I think is underused in our critically ill population. Another intervention in terms of adjuvant that has garnered attention recently is low-dose ketamine. And the evidence was relatively limited. You can see only one RCT that our systematic review was able to find, but quite clear evidence that the use of low-dose ketamine, specifically in the post-operative setting, was able to decrease, again, our opioid requirements. And given this, we came up with a conditional recommendation. We suggest the use of adjuvant low-dose ketamine at the doses shown, specifically in the post-surgical population, with the aim of reducing opioid consumption. Neuropathic medications, specifically discussing things like gabapentins, pregabalin, carbamazepine, also potentially have a role in the ICU setting as their role as adjuvant pain medications. You can see in terms of pooled analysis, really no real effect on ICU length of stay or time to extubation, but again, fairly significant reduction in opioid requirements. And as such, came up with a conditional recommendation for the use of neuropathic agents, specifically after cardiovascular surgery. And the only reason we added in that stipulation was that because of the majority of the data came from this population, and without data in the medical subtypes, is that the members of the guideline panel felt uncomfortable extending this recommendation to others. Now, not to say that medical patients probably wouldn't equally benefit. I think that this is specifically an area where further work should look at the role of neuropathic agents in our medical critically ill patients. Not only did we offer recommendations in each of these domains, but very importantly, we also identified evidence gaps in each of these domains. And these were some of the gaps specific to the pain section. I mentioned that we really do require larger RCTs looking at the role of these adjuvant agents. Almost all of our data that's available is really in the post-surgical population and not a lot in medical patients. I would say as routine, the randomized controlled trials do a very poor job in reporting harm outcomes, especially the more rare harm outcomes. And for a lot of the medications, the optimal dose and route remains unclear. The next domain we're going to discuss is the agitation sedation domain. And one of the mainstay questions within this section was the use of light versus deep sedation. Again, we did pooled analysis, and you can see that the main difference in terms of using light sedation as compared to deep sedation is really in that time to extubation outcome. And as such, and this is a relatively intuitive recommendation, I think, is that we made a conditional recommendation for using light sedation as opposed to deep sedation in critically ill, mechanically vented adults. We really do lack consensus in terms of definitions around these different sedation levels, and unclear in terms of the titration or change in sedation level and its effect it has on patient outcomes at the time as well as long-term patient outcomes. In terms of how we achieve light sedation, I think that there's a couple of different approaches, and you've probably seen these described in the literature, between something like a daily sedation interruption where we just shut off all the sedation, allow the patient to wake up, hopefully coordinate our spontaneous breathing trial around the same time. If a patient gets agitated or delirious, we reinitiate sedation at that time. Versus the alternative would be more of a nursing-led or nursing-driven protocol in terms of achieving light sedation. There's a number of RCTs that have compared this, and what I would say overwhelmingly from these RCTs is that there's an incredible amount of heterogeneity in terms of the different protocols that were looked at and the different ways that daily sedation interruptions were achieved. Nevertheless, we sort of said, given this heterogeneity, that probably either approach is okay when you're targeting light sedation, whether it be daily sedation interruption or nursing-led protocol, as long as we're doing something and not just leaving patients snowed in high-dose infusions every day, but we're actively working to try and decrease the amount of sedation and analgesic that they're receiving. If we do need to use sedative, which sedative should we use? This is data from the critical care medicine meta-analysis led by Dr. Fraser, which specifically compared benzodiazepine sedation regimes versus non-benzodiazepine regimes based more with propofol as well as ketamine. And what you can see is that there's a potential signal towards improved ICU length of stay as well as duration of mechanical ventilation with non-benzodiazepine regimes. And again, a consistent recommendation that if you do need to use sedation, probably avoiding benzodiazepine-based sedation infusions is the best approach. Immobility. The one main PICO question that the immobility group dealt with was the use of early rehabilitation and mobility interventions in the ICU. Despite the fact that this sounds very intuitive, there's still been a fairly significant amount of research into this area, really with the argument that if we are providing early rehabilitation, that it's probably going to be beneficial, we think, although it hasn't always borne out in the data, but there's resource considerations and cost considerations, and is it worth the investment for the output that we achieve? I'll present the results from the meta-analysis looking at pooling all the data around early rehabilitation in critically ill patients. I'll mention that there was a fair bit, again, of heterogeneity around these protocols and these interventions, but overall it seemed like early rehabilitation improves muscle strength as assessed by MRC score at ICU discharge, decreases the duration of invasive mechanical ventilation, really no clear effect on hospital mortality, and an unclear or heterogeneous, inconsistent effect on physical function. Given this potentially small benefit weighed against the cost and resources that I described, we made a conditional "we suggest" recommendation for performing rehabilitation or mobilization in critically ill adults. Certainly the implementation of this recommendation is heavily influenced by feasibility. Every ICU has their own issues in terms of availability of resources, personnel, and trained personnel being able to provide these interventions. I think one of the greatest additions to the PADIS guidelines this year was sleep. I think sleep is critical to our ICU patient population and very underappreciated the impact that a good night's sleep can have on the well-being and outcomes of our ICU patients. We looked at non-pharmacologic interventions to improve sleep with the idea that this is probably where the money really lies in terms of improving sleep. This is a summary table of the non-pharmacologic interventions. The ones in green were the conditional recommendations we made for the intervention. The ones in red, a conditional recommendation against. And the ones in black, situations where the balances between benefits and harms were closely weighed and we made no recommendation. So a conditional recommendation for assist control or full ventilation at nighttime, really saving weaning efforts for the daytime and resting patients so that they can sleep well at night. No clear recommendation for the use of adaptive ventilation like PAV or NAVA or the use of NIV-specific ventilators. Recommendations against aromatherapy, acupressure, and music. Music's an interesting one, and again, fairly heterogeneous literature when you look at it. I think there's probably a subset of patients that music would be beneficial in terms of improving sleep. And I'm specifically thinking about patients that are used to falling asleep to music even when they're not in the ICU, before they got admitted. And probably, again, the best efficacy when patients are allowed to choose their own music, as opposed to we choose what music we think is best for patients. So it requires at least some family input in terms of music selection, or if the patient's able to interact and suggest what music they think is best. In those settings, perhaps the recommendation might change in terms of music for improving sleep. Noise reduction and light reduction, I think, are the two areas where we could probably improve things the most. ICUs are noisy places. We don't do a lot to help decrease those noises at night. And the use of lights, we've all walked through our ICUs where the nurses are doing care, or the lights are on at 4 in the morning, when this is the time where we should really be trying to maximize our environment and making a conducive environment to allow for sleep to occur. In terms of pharmacologic interventions to improve sleep, we looked at melatonin. I'm taking melatonin while traveling across the world to try and improve my own sleep, so lots of potential rationale for why it might work in the ICU. Despite this, only 3 small RCTs, all done in relatively low acuity patients, and not a lot of data on patient-important outcomes. Given that, the panel did not feel comfortable making a recommendation around melatonin for sleep. Dexmedetomidine, specifically with the goal of improving sleep, again, 2 small RCTs. Inconsistent impact on polysomnography and stages of sleep. This is one of the biggest issues we found, or I found as a methodologist looking at the sleep data. You might see that a specific intervention improves stage 1 sleep, decreases stage 2 sleep, but how we interpret this and apply this in terms of a level of patient importance is very unclear. So I think one area that could definitely improve in this area is better highlighting what outcomes are important to patients when it comes to sleep, whether it's duration of sleep, patient-reported duration of sleep, or daytime somnolence. I think that this reliance on stages of sleep has its limitations. Given that there was no impact on patient-important outcomes, again, we made no recommendation in terms of the use of dexmedetomidine to improve sleep in critically ill adults. A number of studies looked at a sleep-promoting protocol. These protocols had different elements as part of them, but overall, it seemed as though some sort of sleep-promoting protocol was able to decrease the prevalence of delirium, and as such, we suggested that using a sleep-promoting protocol, again, similar to sedation, we're not sure how best to do this, but as long as sleep is on people's mind and we're thinking about it as clinicians, there's probably benefit. Out of all the sections, sleep probably has the most in terms of evidence gaps. And we already talked about the issues around outcomes, about methods to measure sleep and classify sleep, as well as sleep-related risk factors, as well as looking at different non-pharmacologic and pharmacologic interventions to improve sleep. The last domain is delirium. Again, we've looked at a number of medications, both to prevent and to treat delirium in our critically ill population. This specifically in terms of prevention, none of the data has borne out in terms of these medications preventing delirium. Haldol, atypical antipsychotics, dexmedetomidine, statins, ketamine have all been explored in terms of preventing delirium in our ICU population without benefit. In terms of treatment, we've heard lots about this from Wes already with Mind ICU and the REDUCE trial. And consistent with those latest RCTs, we made a recommendation against routinely using Haldol or atypical antipsychotics to treat delirium. Now, that being said, with a similar caveat that Wes made, that if a patient is being unsafe to themselves or unsafe to the healthcare practitioners, nurses, respiratory therapists, doctors, there may be a role for antipsychotics in this situation for a safety perspective. Finally, dexmedetomidine for the treatment of delirium. 1 small RCT did show a reduction in ventilator-free hours with no effect on length of stay, and we did make a conditional recommendation for the use of dexmedetomidine in those patients that are on mechanical ventilation, delirious, and agitation is the main issue that is precluding weaning. That's my brief 20-minute summary in terms of the different domains of the PADIS guideline. I think we've already heard lots, again, from Wes about the 8F bundle. I think this 8F bundle represents a nice, handy way that one might apply the PADIS guidelines at the bedside in the management of our critically ill patients. Not necessarily something that you absolutely have to use, but a handy way of incorporating those 5 different domains and many of the recommendations that I just hit on into our practice. And with that, I thank you for your attention and would be happy to take questions afterwards. Thank you.